the fact that there is a subendocardial ischemia, because of course, even if the muscle is thicker, the coronary arteries are not more voluminous or more numerous, and so the subendocardium of the left ventricle does not receive enough blood from the coronaries as related to the thickness of the myocardium. The patients can also have palpitations. They can also have syncope due to arrhythmias. But the syncope can also be due to the obstruction itself. If there is a very severe obstruction in the outing of the blood from the heart, then there is not enough blood coming out, going to the brain, for example, or to the muscles, and then the patients can have syncope. So these are the main features: dyspnea, angina, palpitations, and syncope. One patient can only have maybe one of these features. There can be also asymptomatic patients, but the most severe clinical picture can include all these features. When you listen to the heart, you do the auscultation, you would hear a parasternal ejection, systolic murmur. It does not have a carotid irradiation, different from the aortic stenosis, because this is due only to an event happening just below the aortic valve, and it is not irradiating on the aorta. And there also can be a mitral regurgitation due to this systolic anterior movement of the valve. You will see it quite immediately in the echo images. And you can hear that murmur as well. This murmur, especially the ejection murmur, will increase when you reduce the cavity of the left ventricle with some maneuvers, like, for example, the Valsalva maneuver, or standing from a squat position. So the patient, you ask him to sit down in squatting, and then you say, now come up, stand up. You listen to the heart and you hear it better, because there is more blood coming quickly back. In the Valsalva maneuver, there is usually an increased pressure in the thorax. The preload of the left ventricle is decreasing. The ventricle becomes quite small, and it is already small due to the thick walls. It's even smaller, and the obstruction is more severe. And so you hear better the murmur. So these are maneuvers that can increase the murmur. Also, if you give the patient some nitroglycerin, which is actually to be avoided in the therapy of the patient, but just as a test, you give some nitroglycerin under the tongue, under medical supervision. And due to the fact there is a vasodilatation of the arteries, and there is bigger difference in pressure between the left ventricle and the aorta, the pressure, the obstruction gradient is increasing. You hear better the murmur, and you see it better also with echocardiography. The ECG can show various changes. Of course, the most typical change, being called hypertrophic cardiomyopathy, would be that you could find left ventricular hypertrophy on the ECG. But you can also find other things, like the P wave would be changed with left atrial anomaly or dilatation. We will see it on an ECG. There can be atrial fibrillation as well in the evolution of the disease. The PR interval can be normal. And I say here changes can suggest etiologies, because a short PR was described in Fabry disease as an etiology, or in some mutation like the one in PRKAG2 gene, PRKAG2 gene. A long PR interval would suggest some fibrosis or infiltration of the AV node, and it can be related, for example, to amyloidosis. You could also find abnormal Q waves due to fibrosis, and also STT, secondary strain changes with negative T waves, which could be giant negative T waves. And here you have some examples. For example, on the top tracing, you see the giant negative T waves. You see the T waves are 15 millimeters depth, really, really deep. Here as well, some negative T waves. The P wave here, you see it best in V1, has an important negative component, suggesting a left atrial anomaly. Down here, for example, you see a very short PR and a delta wave. The P is just before it's really into the QRS complex, and this could be a PRCA2 mutation, which can be associated with a Wolff-Parkinson-White short PR and delta wave pattern. Of course, the diagnosis itself is usually made using imaging. And from imaging, I'll show you some echocardiography and some cardiac MRI, but other imaging techniques can also be used. And here are very nice and sort of, you know, the typical textbook images of a hypertrophic cardiomyopathy. If you look at the top first image, the left image on the top row, you see a parasternal left axis with a very thick interventricular septum. It's around 24 millimeters, and I was saying the definition is above 15. The mitral valve that you see here is collating, is going towards the septum in systole. You see it here. And the effect is there is also, in a four-chamber view, an important mitral regurgitation that you see here. And here on the Doppler image below, you can see this sort of, we call it a sword-like image, a sword-like shape due to the gradient. The gradient is measured to be 118 millimeters mercury between the left ventricle and the aorta. So it's a very high gradient. High, abnormally high is above 30, and here we have 118. And here are some images using transesophageal echo. And again, you can see here very nicely something that is similar to the GIF I showed you before. This is the interventricular septum here. It is thick. And here is the mitral valve. And you can see how the anterior valve, the mitral valve, has a systolic anterior motion. It goes towards the septum, and it creates here this mosaic of colors that you can see here in the outflow tract of the left ventricle. Means turbulence, means very high velocities. The valve is long. Here it's measured, it's 3 centimeters. Normally it's around 2 centimeters, and it contributes to it. So obstructive hypertrophic cardiomyopathy is due to a thick interventricular septum, the systolic anterior motion, the sum of the mitral valve with the long valve, and it also leads to this flow that you see here, up here, which is the mitral regurgitation, which is usually severe and is due to the mitral valve abnormality. Here you can also the cardiac MRI. In the cardiac MRI, you can see this is the heart here. You see nicely moving, and you can see that the interventricular septum again is very thick, and the cavity is almost closing, and you can see the obstruction with very accelerated velocities here in the left ventricular outflow tract. And here we have the coronary angio, just depicting in this patient a muscular breach of the coronary. The coronaries are absolutely clean. There is no atherosclerosis, but there is a muscular breach constricting the left anterior descending artery and leading to a stenosis. But it's a dynamic stenosis, and it's again due to the hypertrophy of the left ventricle. Here are some MRI images of apical hypertrophic cardiomyopathy, and you can see here how the apex of the heart, the top of the heart, the apex of the heart is hypertrophic. The basal segments of normal thickness, but not the apex. The apex is thick, and this is in both cases correct. What is the management of hypertrophic cardiomyopathy? It depends on the form. As I said, there are forms that are obstructive hypertrophic cardiomyopathy, and there are forms that are non-obstructive, where, for example, the apical forms or the forms that are not involving the basal septum will not lead to obstruction of the left ventricle. In obstructive hypertrophic cardiomyopathy, we use drugs that lead to a decrease in inotropism, in contractility, like beta blockers or verapamil or disopyramide, and these are decreasing the obstruction. Some patients answer very well to medical treatment, and they can have a very good evolution just with pills. But if pills don't work, then we use septal reduction therapy, which means that either by surgery, called myomectomy, or by an interventional technique called alcohol septal ablation, we do a thinning, a sort of thinning of the interventricular septum, basal septum. The surgeon, for example, cuts a slice of the interventricular septum to make it thinner and to lead to the dispersion of the gradient of the obstruction. If the patient has arrhythmias like atrial fibrillation or ventricular arrhythmias, then we can give them either drugs like amiodarone or primary or secondary sudden cardiac death prophylaxis with an implantable cardiac defibrillator, an ICD. If the patient has a non-obstructive hypertrophic cardiomyopathy, we don't need to care about obstruction, but we give the patient heart failure therapy with diuretics or ACE inhibitors or beta blockers. Just, standard heart failure therapy. We use any of these in order to help the patient, but paying attention to the fact that usually the heart is not very dilated, so with diuretics, the patients could have low blood pressure, for example, and this patient can also have arrhythmias. That's why the arrhythmia management is common to both forms. So these patients could also need amiodarone or ICD. In obstructive hypertrophic cardiomyopathy, you should not give nitrates. I was telling you that nitroglycerin increases the gradient. We use it just as a test if we feel that we need it for diagnosis, but we never give it as a treatment. And digoxin, because with digoxin you get higher contractility, and with the obstruction this is very bad for the patient, for the heart. If the patient has atrial fibrillation, you should restore the sinus rhythm whenever possible, because they don't tolerate well atrial fibrillation. Always the patient should be anticoagulated. It is irrespective of the CHA2DS2-VAS score. And here you have images of a patient who was operated with myectomy. You have here on the pink panels, it's the pre-surgery, and you see very nicely, I hope, how the mitral valve, so the pink panels look on top and bottom. The mitral valve makes a sort of golf club. You see the movement, and it goes towards, it hugs the interventricular septum. I hope you all see it, and see it well in the transesophageal echo as well. In the post-operative images with the green panels, you see that the mitral valve is not hugging anymore the septum. The septum is somewhat thinner, not so thick as here, because a slice has been cut on the septum. All time the blood to get out of the liver, there's a barrier. But who cardiac had a cardiac, this is compulsory. But also, if the patient has features leading to high risk of sudden cardiac death, we also implant an ICD in what we call a primary prevention. We try to prevent sudden cardiac death. And the European guidelines have a calculator in which we include the age of the patient, the maximum wall thickness, the left atrial size, the gradient, but also the history of sudden cardiac death in the family, of syncope in the patient, and of ventricular tachycardia. And there is a risk of sudden cardiac death at 5 years that should be computed. The calculation leads to a value, and if the value is lower than 4%, then the risk is considered low and we don't give an ICD. If the value is above 6%, then we consider that the risk is high and we put an ICD in these patients. And then there is an intermediate value, and then we can take into consideration, but we have to very carefully balance the risk and benefits of the ICD. So high risk is above 6% from this calculation. I was telling you that most of these patients have genetic cause, so genetic testing is useful. With the genetic testing, we can find a definite mutation, for example, in myosin binding protein C3 gene, MYBPC3. We find this mutation, and it is very useful not only to confirm the etiology of the disease, but also to do a cascade genetic testing in the family. We can then test the children of this patient, the parents of this patient, the brothers and sisters, and to see if there are other cases in the family. If we don't find a mutation, of course, then we just do a cascade clinical screening and we look at the ECG and echo. Now we're halfway through the lecture. What I will do, I will give you a 5-minute break where you can drink some water and move a little. And I will take my headsets and I will try to see if using this, maybe you don't hear the background noise as much, okay? So please, let's reconvene in 5 minutes, okay?
Thank you.
Thank you.
Mai stăm sau ne da pauză? The
The professor told us that
Thank you very
she
much.
was giving us a break. And
Thank
she
you very
didn't
much.
come
I
back.
didn't hear. I didn't.
She's half of the lecture. She didn't finish. To get
Okay.
her headsets because there was a lot of
Hear the last part. That's why.